So tonight we're going to start a presentation, prostate cancer, to screen or not to screen. The outline will follow as such PSA screening as well as the United States Preventive Services Task Force recommendations, followed by active surveillance, a discussion briefly of robotic prostatectomy, and then lastly cryotherapy. I'm going to discuss PSA screening and specifically the United States Preventive Services Task Force recommendations. On October 7th, 2011, the task force published draft recommendations against prostate-specific antigen, or PSA screening, for prostate cancer in asymptomatic men. Now, these are all men. The United States task force gave it a D recommendation. And what that means is that there is moderate or a high certainty that the service has no net benefit, or that the harms outweigh the benefits. And the task force discourages the use of this service. The purpose of tonight's discussion is to further dissect regarding the use of the PSA screening in prostate cancer and evidence to support the continued use of this important biomarker as an important screening tool for prostate cancer. Prostate-specific antigen is secreted by the prostate predominantly, but not exclusively. It's nonspecific, and there's no well-defined cutoff points. As much as that we would all like to think there is cutoff points available, I'm going to discuss briefly, why is this not the case. And furthermore, the utility of PSA kinetics is quite often debated. From the SEER database, which is a national registry, the prostate cancer incidence, as depicted here, in the 1990s when PSA became available, there's a sharp increase in the incidence of prostate cancer, which one would expect. Now, something to look further into this diagram is that the 75% decrease in metastatic disease diagnosed during this PSA era. The mortality of prostate cancer has decreased over the years. However, what can also be observed, which cannot be fully appreciated here, is that there's a 40% decrease in the age-adjusted prostate cancer death during the PSA era. Now, this chart depicts information from the Prostate Cancer Prevention Trial, which is a large randomized trial from the Southwest Oncology Group, and which revealed that prostate cancer can be diagnosed at any PSA level, and not the historic cutoff to trigger a biopsy or referral of a PSA of 4. The data presented here are from the control arm of the trial, where after 7 years, all 9,000 men with normal digital rectal exams and PSAs less than 4 underwent prostate biopsy. Now, what's depicted in this slide is that, as you can see, high-grade, or better known as clinically significant cancer, can also be diagnosed at low PSA levels less than 4, with incremental increase in detection with increase in PSA. Once again, all of these men had normal digital rectal exams. As we all know, level 1 evidence is the holy grail for which we base quality evidence-based decisions. There are two very important randomized controlled trials which were discussed in detail in the task force recommendations. The first of which, and all these names are very confusing, but I based them pretty much the European trial, which is the European randomized study for screening for prostate cancer, and then also the prostate, lung, colon, and ovary screening trial. In the European trial, a little over 150,000 men aged 55 to 69 years old were randomized to screening versus no screening. Men were screened at 4-year time intervals, with certain centers such as Sweden at 2-year intervals. At a PSA greater than 4 or abnormal digital rectal exam, the patients underwent prostate biopsy. After a median follow-up of approximately 9 years, there was an overall reduction in prostate cancer-specific mortality by approximately 20%. Now, what's depicted in this slide, and to look into things in a little bit more detail, is some questions remain regarding this reduction. As you can see here, at the year 7 mark, the curves begin to diverge. And the results of this study are from a median follow-up of 9 years. As you can imagine, the further diverging of the curves can be even greater appreciated as one goes in longer follow-up. In addition, once again, the screening intervals were every 4 years. In the American trial, there was less than 100,000 patients aged 60 to 74 years old that were enrolled. Pre-randomization PSA included one PSA only 3 years prior to randomization. A PSA and digital rectal exam were performed each year for 4 years, and then PSA each year for 2 years. The prostate biopsy was performed much the same as the European trial, PSA greater than 4 and/or abnormal digital rectal exam. Now, the follow-up here was less at 7 years, but I think what's equally as important, or more so, actually, is the screening contamination of approximately 52% in those that were in the control arm. They noted no significant difference in prostate cancer mortality. So the conclusions of these two studies, the American trial or the PLCO trial, there was no significant difference in prostate cancer specific mortality. However, there was a 52% contamination rate. In the European trial, PSA screening resulted in significant decrease in prostate cancer specific mortality, with a relative risk of about 20%. So my question to you, or I always ask myself, is which data do you believe? And I think what I always look for is, well, what's the next best study? And fortunately, which was published in Lancet Oncology in 2010, of a study from one of the centers from the European site, Gothenburg, which had a little over 30,000 patients, which were, had PSA and digital rectal exam every 2 years. The median follow-up was 14 years. What they noted was an even greater reduction in prostate cancer specific mortality in the screen group by 44%. What's equally important with this study as well is there was only a 3% contamination. So, taking the prior information at hand, the task force published draft recommendation against PSA-based screening for prostate cancer in asymptomatic men, and the task force discourages the use of this service. The task force based these recommendations on the overdiagnosis, overtreatment, increased morbidity with treatments, and no survival benefit demonstrated with the current PSA data available. And regarding the overdiagnosis and treatment, I would argue that we are underdiagnosing and treating patients based on evidence from 20 years plus of surgical pathologic specimens from patients undergoing radical prostatectomy, where 33 to 50% of the patients were actually upstaged after undergoing the surgery. And basically, the morbidity of the treatments itself have changed with implementation of the newer technology. And I recently published current trends in radical prostatectomy with noted decreased complications associated with this new technology available. And as indicated from my prior slides, the devil is in the details regarding survival benefit. And while the task force did analyze the data available, they affirmatively cannot exclude with 100% certainty that there's no survival benefit associated with PSA screening. The specific recommendations were prostate-specific antigen-based screening results in small or no reduction in prostate cancer-specific mortality and is associated with harms related to subsequent evaluation and treatments, some of which may be unnecessary. While the task force did provide an excellent review of the current literature, several organizations have questioned this disregard for PSA screening. The American Urological Association, on the same day, October 7th was just this day where I never received so many emails regarding PSA and what to do from family members, physicians, urologists, and the AUA immediately responded to this against the task force recommendations. And what they said is the AUA supports the use of the PSA test. And it is our feeling that when interpreted appropriately, the PSA test provides important information in the diagnosis, pretreatment staging, or risk assessment and monitoring of prostate cancer patients. Now, the American Urological Association, as well as the NCCN, which is the National Comprehensive Care Network guidelines, coincide with one another. And I think, at the end of this discussion, I at least want to provide our physicians who are at the forefront of identifying these patients and who to identify and what do they do in regards for obtaining or not obtaining a PSA. the American Urological Association recommends PSA and digital rectal exams starting at age 40. Annual screening if they have these significant risk factors, which is a strong family history, African American, PSA greater than 1, or a PSA velocity of greater than 0.35. With all others to repeat a PSA and digital rectal exam at age 45, and then annually starting at age 50. And I think the most important thing is any further questions to consult a urologist for further clarification. This is a study that I did while I was at Harvard and developed a nomogram which is currently in press to be published in Cancer, which is the official journal for the American Cancer Society. And basically, the end result of this is I utilize PSA as well as other risk factors to discern which patients are at risk for clinically significant cancer prior to prostate biopsy. Now, while the performance of this nomogram was not 100%, it does offer my patients the reassurance that we're utilizing PSA and other risk factors to decide whether or not to proceed with a biopsy to detect clinically significant disease. And from this study, the model itself, I was able to eliminate approximately a quarter of biopsies while maintaining a high sensitivity at detecting aggressive prostate cancer, which in my mind is what we're all trying to do. Until we have improved biomarkers to detect clinically significant prostate cancer, i.e. cancer that may kill you, we should not abandon one of our most useful weapons to combat this disease. The final AUA recommendation and statement that I believe firmly is not all prostate cancers require active treatment, and not all prostate cancers are life-threatening. The decision to proceed to active treatment is one that men should discuss in detail with their urologist to determine whether active treatment is necessary or whether surveillance may be an option for their prostate cancer.